Assalamualaikum everyone. So I am Dr. Shehla Tabassum. I am a consultant endocrinologist, diabetologist in Lahore. I am currently working as assistant professor endocrinology at Akhtar Said Medical and Dental College, Lahore. Today we are going to discuss a very important topic in the diabetes management, that is the insulin therapy. So there are two types of management techniques in type 2 diabetes. One is the oral hypoglycemic agents and other one is the insulin. And we will be discussing the second part, that is the insulin. It's a very vast topic. So वो जिसको कहते हैं कि दरिया को कूजे में बंद करना, वो वाली चीज़ आज करने की मैंने कोशिश की है. So let's see how we will go through this lecture. So our learning objectives will be, we will review the indications. We will compare the strategies of singly using insulin or using premixed or basal bolus regime. We will examine the different insulin types and we will see how the insulin is given in special populations. So if you see, the type 2 diabetes has got a progressive nature. With the passage of time, in the initial stage there is insulin resistance, but when the diabetes reaches the middle stage, there is beta cell dysfunction that basically pursues. And when the diabetes is progressed and it finally reaches the advanced stage, the insulin therapy becomes inevitable. The oral hypoglycemic agents fail to control diabetes at this stage, and this is the stage where basically insulin is indicated. The different trials that, like the UK PDS trial, the ADOPT trials, they all confirm the progressive nature of the glycemia and the beta cell declines that begins early in the disease. So there are two types of insulins. If we look at the physiological review, one is the endogenous insulin, which is produced among all of us. It is secreted in a pulsatile manner. It has got a biphasic release pattern, and there is a portal to peripheral gradients. And then there is an exogenous insulin, which is given in the form of a basal insulin to cover the glucose raised by the hepatic gluconeogenesis. And then there is a bolus insulin, which is given to cover the boluses, that is the food intake. And there is no portal peripheral gradient in this type of exogenous insulin. So basically, when the insulin is given in this modern era, it is basically reserved for the late and the severe type 2 diabetes mellitus cases. There are now newer agents which have got very much additional benefits other than the glycemic control, that is the cardiovascular and the renal benefits. These include the GLP-1 agonists, the SGLT2 inhibitors, and these days insulin is facing tough competition with these other agents as well. So basically, this is the current era of individualized diabetes treatment. If we look at the ADA guidelines, that is the American Diabetes Association guidelines, it emphasizes on tailoring the therapy to individual patient needs rather than a one-size-fits-all approach. So every patient is different from another patient. We have to look at various factors in a patient, and then we have to decide the insulin therapy accordingly. If we classify the insulin, there are human insulin that are more commonly available, that are relatively inexpensive. These include the regular insulin, the NPH insulin, and then there are the analogs. Analogs are the latest types of insulins. They are have got a little bit higher cost. So these include the glargine and the datamir, which are the basal insulin. Then are the aspart, lispro, glulisine, which are the bolus insulins. And then we have got the premixed options both in the human insulins and in the analog insulins. These may include the biphasic analogs, the co-formulations, and the fixed ratio combinations. So then we have got two types of basically insulin. These are the basal insulin and the bolus insulins. How do the basal insulin affect the glucose level in our body? We have got basically three basal insulins available. One is the glargine, other is the datamir, and the third one is the degludan. The most important thing that we have to consider while prescribing these insulin is their duration of action in the body. So the usual one that we prefer to prescribe is the glargine. It has got a 24 hours duration of action, so it is given once a day and it works throughout the 24 hours of the day. There is no specific peak, so there is a very stable coverage. There are no hypos or hyperglycemia. Second one is the datamir, which has got a little bit less duration of action, that is the 18 hours, and there is a very little bit weight gain with this insulin. And the third one is the degludec. Degludec is a long acting basal insulin and its duration of action is more than 42 hours, and that has got a very flexible dosing, so you can inject it at any part of the day and it has not to be injected exactly after 24 hours of the last dosing. Then there are the bolus insulin. So how do the bolus insulin pharmacokinetics work in the body? These include the regular insulin. Their onset of action is slower, that is 15 to 30 minutes. This is very important because from this you can understand that all these regular insulins have to be injected at least 15 minutes before the meals. So they cannot be injected just before the meal because they take almost 15 minutes to start their onset of action. Then there are the rapid acting analogs. They have got a very quick onset of 5 to 15 minutes and they have got a very good postprandial control. They can be injected just before the meal, so they are basically preferred by the people who just don't want to wait after the injection of the insulin for their food intake. So it can be injected just before the meal intake. And the third one are the inhaled insulin. That is, you must have come to know about its name, that is the Afrezza, which is the ultra rapid acting and it has got a pulmonary delivery system. Currently Afrezza is not available in Pakistan, but it has been approved as an inhaled insulin abroad. Then there are the premixed and the co-formulations of the insulin. So there are the most common one are the biphasic analogs, which have got a 70-30 ratio. So 70% is the intermediate acting insulin and 30% is the rapid acting insulins. So these are the insulins like from the human formulation. These include the Humulin 70-30, the Mixtard 30, and if you look at the analog preparations of the biphasic analogs, these includes the Novomix 30, the Humalog Mix 25, the Humalog Mix 50 and the Novomix 50. They are very easier for the patients to inject because they can be injected just twice a day. And then we have got some combinations of long acting basal insulins and the ultra short acting insulins, that is the degludec and the aspart combination. What are the biosimilar insulins? Well, biosimilar insulins are the insulins which provide similar clinical outcomes as compared to the known analog insulins. So they demonstrate safety profiles to the reference products and they are the economical choice of agent in the low and the middle income countries. And because there is increased insulin demand throughout the world, analog insulins are a bit expensive. So the biosimilar insulins have got a big market in the LMICs and they have got a better insulin accessibility. So what are the indications for the initiation of insulin? When do we start thinking that a patient needs to be placed on insulin? First one is if the patient is having severe hyperglycemia and he or she is suffering from the osmotic symptoms like polyuria, polydipsia and the weight loss. These symptoms indicate that the pancreas is on fire and the pancreas needs some sort of rest. So to work as a fire brigade inside the body, such a patient should ideally be placed on insulin so the pancreas is given some rest and the work is done by the exogenous insulin, so that later on the pancreas will start secreting some of its insulin itself. Second indication is a severe hyperglycemia. If the patient is having an HbA1c of more than 10%, then the ADA guidelines suggest that the patient needs to be prescribed insulin. Third one is the oral hypoglycemic agents failure. This is the most common indication when our patient is taking 3 groups of oral hypoglycemic agent and still the patient is unable to reach an ideal level of HbA1c target. This is an indication that the patient needs to be added on an insulin therapy in addition to the oral hypoglycemic agents. And then there are the catabolic states, like a patient is having an HHS state, that is a hyperglycemic hyperosmolar state, or there is diabetic ketoacidosis, which are the typical catabolic states, or there is pancreatitis that the patient needs to be placed on insulin. Now, how do we choose the right regime for the insulin? There are different type of insulin regimes. There is a basal only regime, there is a premix insulin regime, and then there is a basal bolus regime. Basal only regime is a very simple regime that we usually prefer to start a patient initially on a basal insulin, because basal insulin has got a once daily dosing. So as there is a general phobia among the patients about the needle of the insulin, about their fears of insulin, suffering from hypoglycemia due to insulin, so this is the best way to start a patient of insulin. Patient will be injecting a once daily insulin, and the patient will become gradually fearless about the insulin side effects. It has to be injected irrespective of their meal requirement. So the patient is very comfortable that the patient can inject this insulin whenever he wants at the night time, and there is low hypoglycemia risk with this insulin. Second one is the premix insulin. When our patient is having a very high HbA1c level, or if the patient is unable to control his blood glucose levels with a basal insulin, then we move on to the premix insulin that has got a twice daily dosing. It is convenient, but there is rigid timing because it has to be injected before the breakfast and before the dinner. So the patient has to carry it whenever the patient is traveling or the patient has to dine out. Third one is the basal bolus regime. Basal bolus regime is basically, it mimics the physiological insulin in the best possible manner. It is flexible, but there is a high burden, because if the patient is taking insulin 3 times a day, is taking basically the meal 3 times a day, the insulin has to be injected 4 times. So there will be 3 bolus doses and there will be 1 basal dose. So there will be multiple injections, so it's relatively difficult to prescribe in the patients who have got needle phobias. So we basically consider patient's lifestyle, the cost restraints, and the education level whenever we are selecting a regime. So a patient who is illiterate, starting a patient on basal only insulin basically brings the patient to the comfort level, because it's once daily dosing and it can be injected during any time at the night time. Then is the dosing and the titration protocol. So how do we start the insulin? What is the initial starting dose? This is very important. So if you are starting a patient on a basal insulin and the patient is using the other 3 groups of the oral hypoglycemic agents, and we plan to add a basal insulin, the initial dose is 0.1 to 0.2 units per kg for the basal insulin. For example, if the patient weighs around 60 kg, so the 2% of this basal insulin has to be injected. So we will prescribe injection glargine 12 units at the night time in such a patient. So how do we adjust the insulin level? In the future, we basically ask the patient to check the fasting blood glucose level, and then the titration is done after every 3 to 7 days. Based on the fasting blood glucose level, we increase the insulin by 2 to 4 units. Our target fasting blood glucose level in such patients is 70 to 120 milligram per deciliter. Self-titration has proven benefit in studies, multiple trials like INSIGHT, and patient can safely adjust their own doses with proper education. So this is the starting dose of the basal insulin. But what about if we are going to start a patient directly on a premix insulin? Well, the starting dose of a premix insulin is 0.4 to 0.5 milligram units per kg for the insulin. For example, if the patient weighs around 60 kg and I plan to start him on a premix insulin, his total dose will be 30 units. So if this patient is taking 3 meals per day, I will give 2/3 of this dose in the morning and 1/3 of this dose in the evening. So I will prescribe him injection Humulin 70/30, 20 units before breakfast and 10 units before dinner. But if the patient is taking 2 meals per day, that is just the breakfast and the dinner, then we have to divide these 30 units into 2 equal parts. So we will be prescribing 15 units before breakfast and 15 units before dinner. So this is the logic why we prescribe 2/3 of the total dose in the morning and 1/3 in the evening. This is basically for the patients taking 3 meals per day, because then the morning dose will be covering 2 meals and the evening dose will be covering 1 meal. But if the patient is taking 2 meals per day, then the dose will be equally divided into 2 parts. What are the different insulin delivery devices and how do we store the insulin? So the most common ones are, and the latest ones are, the insulin pens. And the other older method of insulin injection are the use of the syringes. Some people feel comfortable with the syringes, but the insulin pens are a very convenient one. They offer improved dose accuracy over the syringes. They are available as disposable or reusable options, and they are most convenient for the ambulatory patients. So these pens are basically the insulator pens. So these pens can be do not necessarily need to be refrigerated. If the patient is having a good room temperature, then with no direct sunlight, these pens can be kept at the room temperature. They can even be carried in the bags or in the pockets while traveling, if you have got an air-conditioned car or if you are traveling through an air-conditioned aeroplane. So they are very convenient to carry if the patient has to go to some place, has to dine out. So this is the reason of their convenience and their increased prescription. Second one are the insulin pumps. Insulin pumps basically provide the digital tracking of the doses. There is an glucose meter which is continuously monitoring the glucose. There is a sensor and it offers the dose calculations and the reminders, and it improves the adherence to the data sharing. Insulin pumps are most frequently prescribed in the type 1 diabetics, and the insulin pumps are currently also available in Pakistan. They are a bit expensive. That is the reason that they are prescribed a little bit less as compared to the insulin pens and syringes, but you must be available that they are. The Medtronic company has got insulin pumps available in Pakistan. Then for the storage of the insulin has to be stored in the cold chain, and we have to maintain the cold chain integrity. We have to rotate the injection sites to prevent the lipohypertrophy, and we have to replace the insulin as per the expiration guidelines. Insulin has always to be stored in the fridge component of the refrigerator, not in the freezer component of the refrigerator. So in this figure you can see that what are the different insulin injection sites. The preferred one is the abdomen. So the whole of the abdomen can be used for the insulin injection. Some people tend to inject the insulin just around the umbilical. So this is wrong. The whole of the front of the abdomen can be used for insulin injection, and a patient has to keep changing the insulin site, injection site, so that there is no lipohypertrophy. Then the insulin can be injected in the thigh, the upper part and the outer part of the thigh. Insulin can be injected in the buttocks. This site is commonly used in the children. And then the insulin can be injected in the upper arms as well. So this is the last and the least favorite site of insulin injection, because insulin basically gets absorbed through the fat. So we have got less fat pads in the upper arms. So this site is reserved only for a few patients. So this is how the insulin needs to be injected. There you can see the technique of the insulin injection. So basically we have to take a fold of our tummy fat between our fingers, and then the insulin has to be injected at 90-degree angle. So this is very important because insulin has to be injected in the subcutaneous layer, and that will be achieved only if it is injected at 90-degree level after pinching a part of our skin between our fingers. Then the role of the SMBG in the non-CGM settings. SMBG is the self-monitoring of the blood glucose, and non-CGM, CGM stands for continuous glucose monitoring. So we have got the continuous glucose monitoring devices like Freestyle Libre, which is injected over the outer part of the arm. But as we belong to a low middle income country, so basically we rely on the SMBG, self-monitoring of the blood glucose, for keeping a glucose track. So in the basal only regime, ideally daily fasting blood glucose has to be checked, and in the basal plus regime, in which we have got basal insulin plus 1 bolus insulin at the biggest meal of the day, we basically take the levels at the pre-meal and the 2-hour post-meal testing. And then there is a basal bolus regime. In the basal bolus regime, almost 4 to 7 times glucose checking is recommended. Glucose is checked before each meal and after 2 hours of each meal, and also at the bedtime. And it is essential for the comprehensive titration and safety. So what is the importance of continuous glucose monitoring in the type 2 diabetes? So there have been various clinical trials like the mobile trial, replace trial, and the impact trial, which have shown that there is HbA1c reduction with continuous glucose monitoring versus self-monitoring of the blood glucose. So CGM is preferred all over the world for a continuous glucose monitoring and the better outcomes in controlling the blood sugar levels. There is improved time in range if a CGM is used, and there are reduced hypoglycemic events. What are the clinical benefits of using the CGM devices? It detects the nocturnal hypoglycemia, it identifies the asymptomatic lows, and it reveals the postprandial excursions as well in a better way. So now we will be looking at the special populations, how insulin is prescribed in the special populations. First one is the chronic kidney disease. So in the chronic kidney disease, there is reduced insulin clearance, higher hypoglycemic risk, so the starting doses will be lower. Then the other is the elderly patients, in which there are less stringent targets, their simplified regimes are preferred, and it is very critical to have their cognitive assessment. So in these two types of population, basically we prefer the insulins which have got a reduced variability like glargine or degludec. So they are basically the peakless insulin, so these are safe in these two types of populations. Then is the other populations like the heart failure and the post-stroke management patient. So in these patients, in the heart failure, basically we want to minimize the fluid retention risk, we want to monitor their blood changes closely, and we need to consider the impact of sodium impact of the insulin in these patients. In the post-stroke patients, we have to avoid hypoglycemia at all costs. Simplified regimes are preferred because these patients became a little bit handicapped after suffering from the stroke, and the higher glucose range targets are used in these patients. Very tight glucose targets are avoided. Then how the insulin is used in the inpatient setting. So basically the basal plus protocol is preferred over the sliding scale monotherapy, and we initiate the basal insulin if the patient is hospitalized for more than 3 days. And the ADA 2025 also recommends the personalized regimes in these patients. Inpatient hyperglycemia management basically requires the structured protocols. Sliding scale insulin alone is inadequate, it is not preferred. Basal insulin provides critical background control even during the NPO states. Then there is a steroid-induced hyperglycemia, as we frequently encounter the COPD patients, the neurological patients who are diabetic and who also have to be prescribed the steroids. So these patients have got very high postprandial hyperglycemia. In these patients, NPH is a very preferred regime because it matches the steroid pharmacokinetics, and it focuses on the post-lunch and the bedside readings. Then there Ramadan and the religious fasting. So Ramadan for the Muslims, and there is religious fasting in the other religions of the world as well. So first of all, every patient who is on insulin and has to fast, that patient should undergo a pre-Ramadan assessment. We have to evaluate the hypoglycemia risk, we have to review the regime suitability, and we consider the pre-Ramadan dose adjustment in these patients. Insulin adjustment, we basically either switch to the basal analogs, and we can even continue with the premixed insulin with a reduction in the basal dose by 15 to 30%. And there is a frequent self-monitoring of the blood glucose or the continuous glucose monitoring during the fasting time, and we check the pre-iftar and the pre-sahur readings, and we also monitor for the nocturnal hypoglycemia. Then the important point is the hypoglycemia caused by the insulin. So what is the high risk population who is very more prone to suffer from the hypoglycemia? These include the elderly patients, the CKD patients, and the patients who are under a polypharmacy use. So polypharmacy basically increases the interaction and increases the risk of hypoglycemia. So what is the emergency management? Oral glucose should be given for the conscious patients, glucagon is reserved for the severe cases, and hospital evaluation should be done for the recurrent episodes, and insulin should be adjusted accordingly. For the prevention strategies, we use the long-acting analogs. We start with the low and go slow approach, and regular SMBG is done. We must teach the patient about the symptom recognition. We must implement the 15-15 rule that the patient, if ever suffers from hypoglycemia, he has to take some glucose intake, and then keep on checking the sugar after every 15 minutes till the blood sugar level is more than 70. And we should create the glucagon rescue plans as well. Now we have to look at some of the side effects of insulin. Side effects include the weight gain and how we can minimize it. So patient gains around 5 to 10 pounds of weight with the insulin, and this weight gain can be reduced to 30% if we add a GLP-1 agonist along with an insulin in a patient. And we must also advise the patient to have a 150-minute weekly exercise target so that the insulin effect on weight is offset. Weight gain remains a significant barrier to insulin resistance acceptance. So some patients are very much reluctant to be placed on insulin due to the weight gain side effect, and combining insulin with weight neutral medication should be our priority, and over titration and resulting defensive eating must be avoided. Then there are some patient fears and misconception as well. There is a needle phobia in around 20 to 30% of the patient. We must address it with demonstration of modern fine needles, and we must consider the distraction techniques as well. Then we have got the fear of dependency. Some people, because elderly people especially, are very much reluctant to inject the insulin themselves. So they are dependent at someone at their home for this injection. We can emphasize on the disease progression nature and explain insulin that it is necessary and has to be used as a replacement therapy. Peer support is very important. So placing a patient on insulin and connecting him or her to some peer who is already a successful insulin user basically improves the insulin adherence and compliance. We can utilize the diabetes support groups. We can share the testimonials about quality of life improvements. Then there are some cultural and social barriers in South Asia as well, like the gender norms limiting, religious fasting, family involvement issues, medication cost and access, and the use of the traditional medicines. So basically placing a patient on insulin is considered regretfully as a stigma in our society. So there are misconceptions like if a male patient is placed on insulin, it will lead to impotency, erectile dysfunction, which is totally wrong, and we must educate our population about these misconceptions. The latest 2025 ADA algorithm also concentrates on a patient-centered approach, and the diabetes management is individualized in these patients. Weight considerations should be made. We must minimize the weight gain potential, and GLP-1 agonists or SGLT2 inhibitors are prioritized before placing a patient on insulin, and SGLT2 inhibitors must be prescribed when a patient has got some nephropathy going on. AI powered insulin management, this is the era of AI. So AI is very much being used in diabetes management, insulin management. AI can be used in data collection in the form of CGM readings, food activity inputs, and pattern recognition. So all the sensors, current sensors which are being used for glucose monitoring, they basically get use of this AI to recognize the patterns and the glucose trends. It can be used, AI can be used for predictive modeling and the decision support as well. Last one is the next generation insulins, which are in the pipeline. One is the weekly insulin icodec. So phase 3 trials have been completed, and it has been approved as a once weekly insulin. Currently it's not available in Pakistan, but it will ease the life of people a lot, especially people who have got a basal bolus regime, who have to inject insulin 4 times a day. So at least we will be able to omit the basal insulin injection from the daily basis to once weekly basis. Then the glucose sensitive insulins, which are responsive to the ambient glucose level, they are being researched. Then temperature stable formulation in which no refrigeration would be required, they are being researched. And oral insulin therapy is early human trials are underway. So the take home message from our lecture today is, so whenever insulin is indicated, it is indicated when the oral medications fail to control the blood sugar level, and it is also indicated when the initial HbA1c levels are more than 9 to 10%. They are the preferred treatment choice in the poorly controlled diabetics. They are the only treatment choice in the type 1 diabetics. So in type 1 diabetics, we cannot prescribe the oral hypoglycemic agents. They have to be placed on the insulin right from the first day. And in type 1 diabetics, please do remember, basal bolus regime is the only regime that can be used in the type 1 diabetics, because they have got marked fluctuation in the blood glucose level, and the basal bolus regime mimics most closely to the natural insulin release in our body. Insulin can be used alone or with oral hypoglycemics like metformin, DPP-4 inhibitors, and SGLT2 inhibitors and GLP-1 agonists. Usually we try to avoid sulfonylureas when we start prescribing insulin to a patient. And personalized basal and bolus regime require ongoing adjustment. Long-term benefits are the early appropriate insulin use reduces the diabetes complications, and proper management improves the outcome and the quality of life. So that's all from my side. Thank you so much for joining me.